All right. Thank you very much. Okay, let's just continue because we are short of time. Okay, so medullary thyroid carcinoma, disease monitoring and extent of surgery. All right, so I'll just talk about an overview of the MTC and then specific properties that will relate to the talk that we're going to do, the extent of surgical treatment and post-operative monitoring, and then we just summarize things a little bit, and I'll give you a short case example. So a bit of an overview, medullary thyroid carcinoma is a rare thyroid malignancy. About 2 to 4% of all thyroid cancers is a part of neuroendocrine tumor in the thyroid. We all know parafollicular C cells, right? So the incidence is more on females, about 1.5 more than males, and most often is in the fourth to sixth decade of life. So the important thing is overall survival rate is still quite good, about 80%. Localized disease has more than 95% of survival, but distance spread will bring it down low to about 40 to 50%. So the specific important properties of MTC that we are going to talk about is the difference between sporadic and hereditary, the secretion of biochemical markers, and the fact that it spreads early. Yeah, central and lateral compartment lymph node metastasis is seen in 14 and 11% of patients with T1 tumors, whereas in T4 tumors, you get 86 and 93% respectively. And MTC with palpable nodules at presentation will have 10% distant metastasis. So the important thing is 75% of MTCs are sporadic, whereas inherited or hereditary MTC is about 25%, and this due to the red germline mutation, red proto-oncogene. So you have the MEN2 and the familial medullary thyroid carcinoma. This will normally be at younger age, always bilateral and multifocal. Right. Biomarkers. So we know that when we are dealing with MTC, we need to look at calcitonin and CA, but they actually produce a lot of other biomarkers like chromogranin and many others. But the most useful thing to be used from screening, diagnosis, prognostication, and treatment decision is basic calcitonin and CA. Yeah. So how we can use this? Basic calcitonin and CA can be used in baseline levels when you actually plan to do surgery after diagnosis. In fact, in the situation of screening, levels of very high, more than 1,000 can actually suggest that there is actually asymptomatic MTC. Post-surgical levels ideally should become undetectable. So this will give us an indication of biochemical cure, and persistent elevation actually can tell us residual disease, recurrence, or potential metastatic spread. The rate of rise is another issue. We can actually look at a rapid increase in calcitonin over time. We are talking about calcitonin doubling time. We also need to look at correlation between CA and calcitonin because these two don't always work together. Yeah, if the calcitonin and CA actually are elevated together, then it shows that there is a carcinoma and probably progression of disease. However, when they actually relate inversely, when calcitonin is decreasing while the CA is actually increasing or stable, it actually shows that there's probably a worse situation. All right, so very high levels of calcitonin, more than 1,000 PG per mil suggests that MTC, like I said earlier, whereas low level in the screening situation basically is depending upon individual context. But more importantly, when we have diagnosed patients with MTC, so we look at these figures that are quite often mentioned, 500 PG per mil, 150 to 200 PG per mil. These are actually thresholds that are mentioned and used along the way in various guidelines to suggest presence of metastasis, to suggest and guide more aggressive surgery, and so forth. All right. Just a bit on calcitonin doubling time. I have to tell you, I have not done it. I'm just reading off whatever that I have read. It's a valuable prognostic indicator. Shorter calcitonin doubling time, less than 2 years, or some events are more within 6 months or so shows more aggressive disease course with higher risk of recurrence or metastasis, whereas longer ones are less aggressive disease. It helps to guide treatment decision like that. Correlation, I have actually mentioned just now. So when the CEA is stable, but the calcitonin is decreasing, it shows actually there is probably more aggressive or poorly differentiated part of the MTC. Now, early cervical lymph node and distant metastasis. I mentioned that they actually present early with that, and actually they actually have metastasis in 70% of cervical lymph nodes if you have palpable thyroid nodule when you diagnose the MTC. So surgical treatment. Surgery, as you know, we being surgeons, and particularly in MTC, surgery is the most important treatment modality. It gives the patient the best chance for cure. So the goal and the aim here is to provide local control of the cancer, maintain laryngoesophageal function so that we don't actually cause problems to the patient after a good treatment. And then we need to actually tailor the treatment according to the type and the presentation, and of course, various other factors. The key issue here that we always talk about is what is the appropriate extent of surgery when we diagnose a patient with medullary thyroid carcinoma. So what are the factors? Of course, hereditary versus sporadic, which is red germline mutation. It is actually the most important, the first one that we need to take into consideration when we want to plan patients for surgery. Basal calcitonin levels, and of course, pre-operative imaging evaluation. What's my next slide? Okay. So, in patients that have been diagnosed and confirmed to have red germline mutation, then we will actually have to plan the treatment properly. Okay, so this will be the one that will determine whether or not we plan the surgery to be whether you can consider less than total thyroidectomy or you must do total thyroidectomy all the time. Hold on a minute. Actually, notes. Okay, tadi. Okay. Right. So surgical treatment options. Number one, basically, we want to decide whether or not hemithyroidectomy is suitable, or we must do total thyroidectomy all the time. And then we also need to consider what happens if we actually diagnose a patient with medullary thyroid carcinoma following a hemithyroidectomy for other diagnosis. Okay, and then we need to consider regional lymph node management, whether we need to do a central lymph node dissection, whether we need to do lateral lymph node dissection, prophylactic, therapeutic, bilateral, all that. And of course, we have to consider all this in the context of whether it is being curative or palliative, right? So the thyroid part in performing thyroidectomy, total thyroidectomy is usually the treatment of choice. The reason being, multicentricity and bilaterality is high. So even in sporadic, it is at least 10%. If you have diagnosed the patient with familial hereditary MTC, then it is 100%. So total thyroidectomy normally gives you the best chance to actually give biochemical cure in these patients. However, there is a possibility that you can actually do less than that. It is because in sporadic MTC, and when the lesion is very small and intrathyroidal, with no no lymph node metastasis seen on assessment, and serum calcitonin level of less than 20 pg per mil, then you can actually omit. Then you can actually do hemithyroidectomy. Well, okay. Right. What do we do for medullary thyroid carcinoma when we have diagnosed it following a hemithyroidectomy? Normally, completion thyroidectomy is recommended, particularly if we have diagnosed hereditary MTC. if we have elevated post-operative calcitonin, which you should do after the diagnosis. And of course, when you do imaging, which of course you should do, if it was not done completely, including CT scan or MRI and showing residual disease, then you should do completion thyroidectomy. So in some certain situation, you can omit the completion in the cases where I have mentioned earlier. Lymph node dissection, prophylactic versus therapeutic, central and lateral, bilateral, unilateral. So in the cases where the disease is confined to the neck, so you know that there is no disease spread, so you can get patients with no lymph node metastasis in the cervical region. Okay. Again, in small intrathyroidal cancer and in calcitonin levels less than 20 pg per mil, you can omit the central lymph node dissection because it's very rare in this kind of situation. But in most other cases, it is recommended that we do prophylactic bilateral central lymph node dissection. In a study of 101 consecutive patients, which is almost 50% sporadic versus hereditary, 50% of these patients have central lymph node metastasis. Whereas if you have ultrasound detected central lymph node disease, then you should proceed with therapeutic bilateral central lymph node dissection with ipsilateral lateral node dissection plus minus contralateral prophylactic lymph node dissection. Lateral neck dissection, again, prophylactic lymph node dissection is controversial, whether you do it unilateral or bilateral. You have to carefully do pre-operative evaluation and intraoperative evaluation of the central lymph node. Okay, when you have a case where you are doing total thyroidectomy, you're doing prophylactic central lymph node dissection, and intraoperatively you notice that there are some abnormal lymph nodes, then you consider as positive central lymph node on table, then ipsilateral prophylactic lymph node dissection should be considered, but you can leave out the contralateral. The reason is because ipsilateral lymph node metastasis is seen in 10% of central lymph node positive patients. If there are 1 to 3 positive lymph nodes, then the ipsilateral metastasis is about 70%, and if more than 3, it's almost 100%. Whereas the contralateral lymph nodes, the rate of metastasis there is lower. All right. Calcitonin level, there are no consensus really, but it is recommended that if the pre-op calcitonin level is more than 20 pg per mil with negative ultrasound, then it's recommended to do prophylactic lymph node dissection in this situation. You can do prophylactic bilateral central neck dissection and prophylactic ipsilateral lymph node dissection. But if the calcitonin level is more than 200, then it is recommended to do prophylactic bilateral central and lateral neck dissection. Obviously, if it's pre-operatively central node positive, then you do it similarly. You use 200 pg per mil as your threshold, and then you do, if it's less, you just do ipsilateral. If it's more, you straight do bilateral lateral neck dissection. In advanced disease, then tone down your aggressiveness because we are now in palliation. So we must make sure that we don't cause them problems related to the surgery. So we can still do total thyroidectomy, central neck dissection, but be mindful of the extent of surgery and resection related structures so that they don't become, they don't have a lot of comorbidities, morbidities after the surgery. Can see, it's a bit busy, but basically I can't see in mine. All right, so this is the ATA guideline, a bit complicated, but as you can see, those are the figures that they use and how they use the red positive or red negative and evaluate for all the concurrent disease that we know, FAO and hypoparathyroidism, and you follow it. The Japanese actually use a simpler guideline, but more or less relying on the red mutation as well as the calcitonin levels. So post-operative monitoring, if you get the best result, which is biochemically cured MTC, then the review is more straightforward. Physical examination 6 monthly for 2 years and annually, serial calcitonin CA 6 monthly for 2 years and annually, and surveillance neck ultrasound depending on the stage or the number of positive lymph nodes. right? If you have persistent elevated calcitonin post-operatively, then you must make sure you give some time, because the calcitonin can drop as soon as the surgery is done. Within 2-3 days, if the calcitonin drop, it means you are getting good results. However, if the calcitonin persisted even after 2 months, it does not mean that your surgery is not good. It's just that the calcitonin hasn't gone down yet. So normally it's about 3 months post-operatively where you actually start to see the real level of the nadir of the serum calcitonin. So if they are elevated more than 3 months, then 30 to 50% of all these cases have a residual disease. So prognosis depends on age and stage. In a series of 900 MTC patients, 57% sporadic, 57% post-op has increased calcitonin, but they still have 70% 10-year survival. So the management is based on the magnitude of the CTN elevation, whether you do that more earlier follow-up or more longer follow-up. So if it's 150 PG or less, then you can see at 2 to 6 months imaging with neck ultrasound, CT or MRI. If it's positive, you consider compartment-oriented surgery. If provided you don't see any metastasis. If imaging is positive, you can go back to the similar follow-up as the one before with biochemical cure. If it's more than 150 PG per mil, then higher likelihood of distant metastasis. Then you extend your imaging to the whole body. Yeah, you can even do bone scan or MRI. There's also possibility to do a PET scan or those kind of things. And then clinical review, continue. If the imaging is negative, then you tone down your the rates and the aggressiveness of your review. If it's imaging positive, treat it accordingly. So treatment option still, don't forget, there is still a possibility of observation in metastatic disease, active surveillance. You can, of course, plan for surgical resection. There's an option of radiotherapy, local therapy if it's very small, like ablation or embolization, or systemic therapy. Now, previously, when we diagnose a recurrent disease or metastatic disease, routinely surgical re-exploration resection was done. However, not all of these patients will actually achieve normalization of the calcitonin levels. So it's not always successful. So careful evaluation on the need, indication to go in to resect or to actually do any treatment and the timing of all this plan is vital so that we don't do things unnecessarily. Because remember, this surgery will be a re-operation. You might want to go back into the lateral neck. You might need to go back into the local area. So the morbidity of the surgery is significantly higher. So to wrap things up, let's just talk about this 79-year-old man. He came to the clinic after a health screening, which showed elevated CA. Clinically, he had a 2 by 1 centimeter nodule on the right side, no cervical lymph nodes palpable, no abdominal mass. He came with a CT scan that showed 1.6 centimeter right thyroid nodule with liver lesion segment 5 multiple liver cysts. He also came with a PET scan. It's on private. Okay, right. Mid-thyroid hypermetabolic 2.1 cm lesion, SUV max 5.1, right lower cervical paratracheal lymph nodes 2.2 centimeter inferior posterior to lower pole right thyroid. And the lesion in the liver turns out to be a metabolic, most likely cyst. Biochemical evaluation, calcitonin 1,816. CA was 52. The screening for FEO and hyperparathyroidism was normal. So an ultrasound-guided FNSC was done, confirmed medullary carcinoma, positive for calcitonin, CEA, chromogranin, synaptophysin. So 79-year-old, CT2N1, M0, calcitonin 1,000, almost 2,000. So he underwent total thyroidectomy, bilateral central neck dissection and bilateral lateral neck dissection. HP confirmed MTC, clear margins, no extrathyroid extension. PT2N1B, 7 out of 39 lymph nodes in the cervical region was positive for metastasis in the right central, in the right levels 2, 3, 4, in the left level 5. What do we do? 1,816 calcitonin. So what happened was, at 1 month, it came down to 64 and 92. So it's not really undetectable, right? So there is still elevated calcitonin level. Post-op CA trend 52 to 56, 5.6. The PET scan referred to oncologist did a PET scan. What do you call it? No evidence recurrent metastasis. Patient is well at the moment, so we're just following him up. So this is the sort of like algorithm for management of patients after treatment with surgery for medullary thyroid carcinoma, more or less describing what I have talked to you about earlier. So in summary, medullary thyroid carcinoma behaves differently than our other more common thyroid cancers. Red germline mutation is very important, and although it is quite difficult in our situation, we can always try to get a surrogate assessment by checking for family history and screening for pheochromocytoma and hyperparathyroidism and all this. But if it can be done, it is very important to determine initially what is the treatment direction, calcitonin levels, as well as imaging will guide subsequent plan. Aggressive surgical treatment in the curative setting gives the highest chance for biochemical cure, and this must be planned so that, if necessary, compartment-based resection of lymph nodes is completed. Metastatic medullary thyroid carcinoma require careful consideration regarding the surgical extent, and the options of other treatment post-operatively must be assessed with all the modalities that is useful for it, so that persistent or recurrent or metastatic disease does not, one, be left alone unchecked, or number two, not treated with treatment that will not give benefit to the patient. Thank you very much.
Okay, now we open for Q&A from any questions. Okay, Mr. Hakim.
Ada talian hayat boleh?
Thank you, Mr. Hakim. Well, calcitonin, I think in my hospital, I'm not sure about in our local setting, calcitonin is difficult to get. They have to send.
Very difficult.
Yeah, so I mean, deciding for the extent of surgery, the neck section, for example, if you want to follow the you follow the level of calcitonin, but I don't think that applies in our local setting. So how do you suggest that we should, I mean, ultrasound, we can do at the lateral neck, but the central is difficult to be set by ultrasound. Would you recommend to do a CT scan to get the central groups or assessment of the lymph nodes before we decide on the extent surgery?
Well, of course, to get the serum calcitonin done in a timely manner, it takes a lot of time. So like in the case that I presented, it was done prior to that, so we knew it already. But of course, if necessary, because like you said, the central compartment lymph nodes can be missed on the ultrasound. If you think it is necessary, anyway, it is part of the staging. You can do the CT scan. We might as well do it, because we are missing a lot of the important factors that we need to actually tailor the treatment properly in our situation. But of course, it doesn't stop us to try and strive to actually move towards that direction. Yeah. So whenever possible, we try to get it. Number two, then we use whatever modalities that we have. It's just that simply because we cannot get the serum calcitonin in a timely manner, then we wait. We go ahead and do all the other imaging assessment, and then we just use that as the basis of how we decide our treatment. Because if we find it on the imaging, consider it as lymph node positive, and then treat accordingly. Daud? Anything against that?
Yeah, have you encountered any medullary thyroid CA with a normal calcitonin and CA level?
No. I haven't encountered that many now. No, sorry. So a normal CA
and calcitonin, but it is actually a medullary thyroid CA.
A normal CAA is probably I have not encountered, okay, but like this, it is said that if it is normal CEA and normal calcitonin, then number one, either it's a misdiagnosis, or number two, whether it is a very advanced differentiation of the medullary thyroid carcinoma. So this is a marker of an even more aggressive disease. That's what the literature says. Huh? I've not seen one. Jawad?
If the tumor markers, if the stain strongly suggests this is a medullary, but if it fails to produce calcitonin, meaning that probably this is not well differentiated, it fails to produce. So we can take this and same like colon cancer. It can have non-raised CA, so it means that it is probably a poor prognosis cancer. Yet in this world, everything possible.
It is just that normally most medullary thyroid carcinoma will produce calcitonin, will have. That's why we can use it as an accurate monitoring assessment tool. Yeah.
I recently have an interesting case. We have a patient with mental lymph nodes over the axilla. So everybody has been putting their heads probably from the breast, we bring MDT, there's nothing in the MRI, nothing in the mammogram. So everybody thinks that this is probably a mocha plus CA. So somebody, they did a CT scan, they find out there's something small in the thyroid. So I did an ultrasound. This patient has a very suspicious looking thyroid nodule, around 1.5 centimeter. When we did a biopsy, it came back as highly suspicious for medullary. However, they failed to do the calcitonin stain because dia punya cell block had failed. So, and also when they tried to take a biopsy from the axilla, it fails. Somehow the pathologist got stain for calcitonin, but it was negative for chromogranin. So now, what I suggest is just go and do calcitonin level and you see how it is. Now, if it came back and calcitonin is very high, the axillary lesion is the lymph nodes in the neck. There is no suspicion. So, if the one in the axilla is metal, okay, is there any no axillary treatment?
Well, this is a situation where let's assume that the calcitonin level is extremely high. Okay, so then if you don't find anything else, then that is probably where it is coming from, and it is basically a metastatic disease. It's an advanced disease. So if the situation in the axilla is such that surgery will cause a lot of comorbidities, there are actually some options of systemic treatment that is, I think, currently being evaluated in, particularly if you actually are able to do rat germline mutation to further characterize the nature of the disease. I can't remember what exactly, but it was something like that. So rather than go in and do surgery, if that is a possibility, but I don't know in our situation. Anyone has any other better comment? Yeah, we need an expert at MTC.
Miss Aina kot boleh recall balik.
Miss Aina ada. Jumpa setahun sekali, 2 kali je.
Calcitonin is normally or rather classical for medullary, isn't it? So I think it was calcitonin level. If it is, then it is. As for the axilla, I mean, worst incisional biopsy to get the tissue something more.
But cuma.
So now it's better. So you know, chances of With the
Then if you confirm calcitonin, can,
What I remember is that if we are able to actually do and test for germline mutation, if it is positive, the current studies is one of those tyrosine kinase inhibitors that is not the usual standard apa ni landmark. It's a different group, selpercatinib or something like that lah. Yeah, it is not, and it is still something that is under investigation.
so it's still under targeted therapy.
Under target therapy, yeah, that's where the added advantage of doing the germline mutation testing. If we don't have it, we can still treat it with some kind of tyrosine kinase inhibitors, but I don't know about the evidence for that.
I mean, MTC can be one of quite recalcitrant and difficult to treat, but it's in terms of mobility and mortality, it's not as high.
It's not.
And the drop like wait and see and
Yes,
how things progress.
yes. Even though it's aggressive, the 10-year survival is actually still quite okay, provided we can do something about it. But in this example is technically more challenging because we are now at palliation rather than curative. Okay, thanks.
So now we will continue with our case discussion by Dr. Surita.